Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. We're thrilled to see so many of you join us here today for the live webinar, Expert Ultrasound Guidance for Accurate MSK Injections. Part 1, the shoulder. You're among 3,700 clinicians who registered for today's popular event. We'd like to thank Ezra, ACIP, and AAOS for inviting many of you to join us here today. In a moment, we'll be welcoming back the fabulous Dr. Alan Hirahara. Board certified in orthopedic surgery and sports medicine, Dr. Hirahara will teach us expert ultrasound techniques to accurately guide a variety of shoulder injections for optimal visualization of anatomy and your needle. We've been blessed in the past to be invited into Dr. Hirahara's private practice to capture videos of procedures with real patients for previous educational webinars. Today, we're kicking off a new series of webinars with Dr. Hirahara to fast-track our ultrasound learning curve for guiding accurate MSK injections by using cadaver segments to explore a wide variety of pain injections. We'll focus today on the shoulder. You can use the questions icon at any time during today's session to ask questions, which we'll address in the live Q&A following the presentation. Let me now introduce you to your host for today's webinar. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Welcome back, Dr. Frankel.
Thanks, Jeunesse. Always a pleasure to be here. And today we're going to set the stage with a quick review of literature before we jump into talking about the specifics around ultrasound-guided MSK injections. I wanted to review a couple papers that came up in our review. The first was actually a systematic review and meta-analysis that kind of hammers home again a point we've reviewed in prior webinars, that ultrasound-guided injections, particularly of corticosteroids, which is where a lot of the data comes from, potentially offers significantly greater clinical improvement over blind subacromial and subdeltoid injections in adults who are presenting with shoulder pain, probably improving their downstream outcomes. Additionally, there's some more specific papers, and this one really looking around all kinds of interventional procedures around the shoulder that suggest that most ultrasound-guided musculoskeletal interventional procedures around the shoulder end up with better results in terms of the accuracy and the clinical efficacy when both are measured than those that are performed in a blinded or landmarked fashion. Next on something a little bit more specific is comparing palpation and landmark again versus ultrasound-guided acromioclavicular joint intra-articular corticosteroid injection. And in this retrospective comparative study, ultrasound-guided injection for the treatment of symptomatic osteoarthritis in the AC joint resulted in better pain and functional status improvement than just palpation-guided IA injection alone. And finally, bringing this technique out into the operating room, our guest is one of the authors on this paper. He'll go into more detail, but just showing the wide scale adaptation and use of the ultrasound for injection also in the operating theater itself, where ultrasound enables surgeons with a safe and a non-invasive tool, particularly in this case for biceps tenodesis, to locate the biceps tendon as it goes and negate the need for unroofing and other additional more invasive techniques to identify anatomy. Before we get into some of the more specifics around the how-tos and Dr. Hirahara's specific practice, we wanted to kind of put this poll up there. We have users from all over the world at different stages of their journey, and to know where people are coming from. Do you use ultrasound to guide your procedures? And if so, how often? Are you using it daily, occasionally, maybe once a week, once a month, potentially soon? Or are you just curious about growing your practice? Leave that open for a second. Here's a short one. Okay, we'll close that out just to kind of see where people are. We're curious about our audience today. Great. So we have a lot of users, some already daily users, some occasional, and then we have some of the curious and exploratory. Great. Perfect audience to invite in our guest speaker, who we're so happy to have back on this series. Dr. Hirahara is a board-certified surgeon in orthopedic surgery and orthopedic sports medicine. He runs a busy private practice in Sacramento, California. He speaks and teaches nationally and internationally with published research on arthroscopic shoulder, knee surgery, arthrobiologics, and the use of ultrasound. Dr. Hirahara is certified to practice both in the US and Canada, and he was recently appointed to the NCAA Committee on Competitive Safeguards and Medical Aspects of Sports, and he's currently involved with the Health and Safety Committee for the Big Sky Conferences. He's a team physician for the California State University Sacramento Athletics and head team physician for the Sacramento River Cats. Dr. Hirahara, we're going to hand it over to you.
Thanks very much, Oren. Appreciate it. And I really appreciate you having me back as usual. This has been just a lot of fun. And this was a lot of fun putting together. And what's been great is trying to really come up with ideas about how to kind of push forward the educational process and help people. And of course, putting these objectives together and going into the lab to be able to do a lot of these newer techniques on cadavers is going to allow us to show people more about how it can be done, what should be done. So let's just start with shoulder injections. And you touched on this, Oren, and very appropriately, that despite overwhelming evidence that there's still actually quite a number of surgeons and quite a number of doctors that don't believe in ultrasound, and that they feel that they're very good and they're excellent and they never miss. But the reality is, as you said very appropriately, that it's just not true. Landmark guided injections are very inaccurate. And the further away from the skin you get, the more inaccurate it will become. And that's something that I learned doing, arthroscopy and doing surgery, is that, realistically, unless you're directly there under the skin, getting to something can be very hard. And the other thing that I learned, and I started doing ultrasound back in 2009, is that once I started doing it, my patients were having significantly less pain doing injections under ultrasound guidance. And that basically told me I was missing. And so really what I tell people is, look, if you're not going to believe me and you're not going to believe the literature, fine. Go get yourself an ultrasound, try it out for a couple of weeks and just see if you see a difference, and be honest with yourself about how it is. You're going to be convinced. But before you start talking about how are we going to learn how to do injections, how are we going to use it to do surgery, you have to understand the technology. And you have to understand it. So this is just one example. And so anisotropy is this artifact that you see. So because normally when we're looking at structures and we're looking at anatomy, you want to be 90 degrees to your ultrasound beam. So you want to be kind of like right there, parallel with your beam. So as your beam's coming down, as long as your structure is perpendicular to it, you're going to see it much, much better. And that's the key point, because as you start to have parallel structures that's perpendicular to your beam, you'll see it. But as it starts to dive off and the structure becomes parallel with your beam, you're no longer going to see it. And that's what anisotropy is. And that's critical to understanding that, because in the body, not everything runs parallel perpendicular. They run in odd angles. So understanding this concept is critical so that when you go to see a simple structure, you're going to be able to identify that it's truly there or not. And one of the pearls is to look for the bone. And if you can make that bone really pop, really bright white line, you are actually doing a good job, and you are now parallel with that, or perpendicular in this sense, to that specific structure. So injections, how are we going to do them? The most common injection is in plane. And I'm just setting the definitions and so that we all can talk the same thing. When you're seeing a needle come in, you're in plane. So you're coming and splitting the beam. Now the beam is like only about 1 millimeter wide. So you have to be really, really good about getting in that plane and not cutting it side to side or being oblique. But if you can and bring it in your beam, it's really good. So the key is when you're doing your injections, you're going to see I'm going to be making these mistakes personally as I show you some of the demonstrations. You really want to be behind your ultrasound unit, looking down the angle of the beam. And when you put your needle in, you want to come into the beam. Give yourself the best chance. Because unfortunately, if you're like this and you're coming this way and you're over here, you may not be able to tell if you're in front or in back or even coming obliquely to the plane. So it's going to be very important to understand how to be in plane well. And that means get behind it, watch it go down the middle, and that's your best way. Of course, going out of plane, that's another way. And of course, there are reasons and techniques to do an out of plane injection. For example, glenohumeral joints, much easier to do out of plane than in plane. We'll discuss that later. But the other thing is, when you're coming down and you're going to be in plane, you really want to be really kind of in plane, in line, in parallel and flat to your transducer. The reason is that if you're coming in obliquely, again, you might be coming down now almost parallel with that beam, such that you're not going to see it. Again, anisotropy. So as you'll notice in a lot of the videos I'm going to show you, you're going to see my needle really well. These are not special needles, they're not expensive needles, they're just basic normal needles. But if you have really good technique and how to do it, you'll image them well. So that's kind of like my spiel about like, okay, how are we going to really do this? But
one tip I'll add is always when I'm teaching the injections, like you said, lining up behind the needle, but then also aiming for the screen what I see a lot of people do is even if they're lined up and the screen's over here, they're turning, eyes off the needle, and then suddenly they lost track of it, right? You really have to kind of keep it in plane, keep it nice, less movement, less body movement, more accurate injection.
I think that's absolutely correct. The only caveat to that is, as a surgeon, I've had to operate like this my whole career.
Yeah.
So I've gotten used to like operating like this in space and doing this. But you're absolutely right, Oren. As you're learning, set yourself up for success. He's absolutely right. That is absolutely the best way to do it. But eventually, you're going to have to start learning how to.
Yeah, you got to do it. Totally.
Yeah. So how do I do the injections? And I think this is like the number one biggest thing. Like I see a lot of people watch me on videos and they'll go, "Oh, he's doing a terrible job. That was not a sterile gel." Or, "Hey, where's your sterile field?" So let's be really clear. I'm a surgeon. I work with sterile gloves, gown, mask, hat, sterile drapes, transducer sheaths, covers, gels, and a sterile operating room every day. So I'm very aware of what sterile technique is. And the one thing that people have to understand who are not in an OR every day is that sterile technique does not mean use of all of this equipment. Now, if you need it for protection and sterility and for doing safety, no problem. So if you need it, use it. But the key isn't that. The key is once you have cleaned the skin, that is now a sterile field. As long as you never touch that area again, except with sterile instruments, and you never touch those sterile instruments with something else, it is a sterile field. And your risk of infection is negligible. Now, obviously, we get infections in surgery, we do, but it's not common. In my 20 years, I have never had an infection from an injection in my clinic. Zero. And the thing is, I have had injections in my surgical, but rare, like we're talking like around 5. But the point I'm trying to make is, please don't think that these things are necessarily. But if you need them, don't feel bad about using them and do use them to be safe for the patient. Oren, do you think that's fair?
Totally fair. Yeah. Whatever degree, I think at a minimum, whatever touches the skin and goes in, especially into a joint, needs to be sterile. But, cleaning the skin, nothing dirty touches that spot, and then you have a sterile needle, you're not like licking the needle before you put it in. It's usually pretty good.
Absolutely. I mean, and that's why, necessarily, like, even if you don't, we all wear gloves, but if you don't wear gloves, that's not a problem for the patient. Okay. So here's another example sterile technique. So I've got my transducer on there. I'm cleaning the skin with iodine. I'm going to use alcohol swab to wipe that off. I'm going to use an ethyl chloride to actually numb the skin up so that, and it's been shown in multiple studies that ethyl chloride does not contaminate the skin or give you problems. And then, of course, I would just come in with my needle and give my shot. Now, I'm not giving a shot in this situation. I'm just giving you an example of how I would do my sterile technique for the person. All right, now let's jump into biceps tendon groove injections. Now, if we talk about biceps tendon groove injections, there are many ways to do this. And the only wrong way is the one where you miss. So really, whatever way works for you is good with me. This is an example of how to do an out of plane. And you'll notice my needle's coming in, and at first I'm not in the groove. You can tell. But then boom, I've readjusted, and now you see that groove filling up. So this is an example where you're going to come down in plane using your probe as your guide of where you want to go, and then triangulating, getting to that spot blindly, but you're not going to see your needle. Here's another example of in plane, where you're actually coming in the plane, getting down to that sheath. And actually, I actually think I missed it here. Actually, I don't think that's actually in the sheath, to be honest. I think it's just outside the sheath. But you can get down into that area. But the point is, that's an example of in plane of how you would do it. Actually, I don't use any of these techniques anymore. I have a better one, but that's the whole point, right? You have to have multiple ways to get something and to do something. There's no one way that's perfect for every single situation. So know the different ways, because sometimes a different technique might actually work better for whatever you're trying to accomplish. So here's an example. The biceps groove is really easy to find because you can see it. And so where you are in the groove from superior to inferior is all about you, about where you want to be. So do you want to
This is the bicep tendon right there.
Yep, thanks. Yeah, exactly right. So there you've seen the biceps tendon. And what I would recommend for this type of injection is you keep yourself in short axis. So you're seeing the biceps in cross section. You would then move your transducer, your probe out of the way, come in laterally, and then you can see that needle come in, and then boom, it's really easy. If you've seen the needle the whole time, you're going to get right into that sheath. You can get into the tendon if you want to, or not in the tendon if you want to. Make sure you're in the right spot and fill it up. Now, you'll notice that I'm doing not a good job here. Like, admittedly, like you saw the needle come in, here you see the needle well right now, but you saw the needle go away for a while. That's because look where I'm standing. I'm not looking down the barrel, so I'm making this hard on myself to get out of the way of the camera. I had Shelly behind me yelling at me, going, get out of the way, get out of the way. I kept getting in the way. So I had to do this kind of like a little bit more difficultly. Now, the other thing that's important here is like where you want to be. A lot of times you're going to want to be on that medial side of that groove because there's a specific vessel that runs laterally, and so you don't want to hit it. And you want to be careful not to get to that area. But you could, if you want to be there, as long as you turn on your Doppler and see it pulsating, you don't hit it, you're fine. But I'm just showing you that you can go either way. And of course, you can move the arm, internal, external rotation, to bring that groove to yourself. And that's what's nice about that. The other thing that you can really do with this is, let's say you wanted to do a subscap injection, because as we all know, biceps pathology is often secondary to a subscap partial tear of the superior 1/3. So it's very common to have that biceps being able to sublux in and out because of subscap pathology. So if you have biceps pathology, you have to think, is it from primary biceps of the tendon? Is it from the labrum, which is not going to be helped by this injection? Or is it secondary to a subscap, which is partially torn, allowing that biceps to mechanically come in and out? So you may want to do a subscap tear. So here you can see I've now simply externally rotated the arm and then just come up over the groove, over that lip of that bone, and you're right there at the subscap, because that's actually less tuberosity when you come superior enough. So this is a way you can actually just do both shots right away at the same time. Piece of cake. Oran, do you like this technique? What have you done?
Yeah, I have never really done many. I can't say I've done subscap injections, but I have injected a lot of bicep tendon. Yeah, and I love your come in lateral technique with in plane. That's pretty great. I'm going to try that the next time. I've never done it that way.
This is just really easy. And the other thing that really lets you do is it makes you determine where you want to be in the groove. Like, for example, if you want to have that injection flow down through the entire biceps, start higher in the groove, you know, and it can really help you decide where you want to be. All right, let's move on. So that's for biceps. Now let's talk about supra and subacromial injections. So we talked about subscap. Now the thing is that there's so many ways you can do this. And I hear so many doctors saying, oh, I'm so good at this because I just follow underneath the acromion posteriorly. Well, what people don't understand, especially non-surgeons, is that if you go and we enter into the subacromial space commonly by putting our scope in posteriorly and then cleaning off that area, because oftentimes if you're coming under the bone, under the acromion, that supraspinatus could actually adhere to the top. And remember, a bursa is a potential space. You don't want the bursa to be filled up. So it's not always got like this big space with a lot of stuff. Now in this picture, you're seeing a bursitis with fluid in the bursa. Duh, easy, right? Piece of cake to hit. But it's not always like that. So even if you follow the bone up, you're not necessarily going to get to the subacromial space coming posteriorly and following the bone. It's not as easy as people think it is. And that tissue can adhere itself. So that's why this is better for the patient and is more accurate, because when we do it away from the acromion, we can see that double hyperechoic line of the paradeltoid fat. And then you're going to be able to really get under that fat and get to the subacromial space correctly, the bursa correctly. So that's why I do like taking the arm back. I do like using that elbow tucked in, and then seeing this image is really nice. And so as you can tell, as we go ahead and run the video, I can just bring the needle in, hit my spot, fill it up, and I'm out the door. It takes 2 seconds.
Yeah, and like that wasn't sped up. That's actually how long it takes.
That's correct.
You know?
That's right. It's just
and I think it's worth emphasizing, like all the data that people kind of hide behind when they still talk about, why they're so good with landmark injections. I feel like we've talked about this before, that it's really predicated on steroid injections. And so you're like dropping these nuclear bombs, molecular nuclear bomb, in there. And as long as it was close enough, you got reasonable outcomes. But especially if you're moving into orthobiologics and things, which is not really the topic today, but I know you do a lot of that, precision matters way more now than it did. And so getting these injections really where you need them is so much more important. Like, look at how tiny that space was on the subacromial space where you injected, there's no way you would hit that blind.
Well,
No way.
on top of that, that was actually filled up with fluid. That was a bursitis.
Right, yeah, that was already. Right.
Typically, you don't even see it like that. Like we're going to see on the next image, the next video, like there was no fluid and you have to get to a potential space. So here you go, right? So you got to like, there is no bursa, in terms of here. You have to like find the spot, get under that double hyperechoic line and basically fill it up. So you're going to see my needle come in now. This is with the cadaver, of course, and then get under that line right there. And then boom, there you go. I'm going to fill it up. Now, I'm not going to, for the purposes of this video, like there I am now in the perfect spot, and I'm not going to inject fully because I don't want to blow up my image because I want to use this for other things. But basically, you can see I'm going down. It's hydrodissecting that plane along. If you just fill up a bubble in that spot, you've missed because you're now in soft tissue because it should fill the whole area, the bursa. And so where my needle is right now is in supraspinatus. And what I'm showing you is that, if you're using orthobiologics, not cortisone, because you can't do this with cortisone, you can get into a partial tear and fill it up with an orthobiologic, trying to get some healing to occur. Also, what's nice is that this is another way you can also, as you can see now, I'm going to push past that. You see that dark area just above the bone on the humeral head? That is not joint space. That's cartilage. Exactly. That's cartilage. Don't aim for that and think, oh, I'll fill the joint. You've now taken cartilage off. Don't do that. But like I said, that once you're past that supraspinatus insertion, you can get to the joint safely and inject the joint right there. And so that I can be in the joint there. So now I don't want to inject my joint spaces like this because it has more danger going close to the cartilage, right? But if you're already here doing an orthobiologic and you want to get some into the joint, it's easy to do it. So this is like the triple threat. You can get into the tendon insertion, you can get into the subacromial space, and you can get into the joint. And this is also used if you have calcific tendonitis. So if you've got calcific tendonitis and you're trying to break it up with an orthobiologic, with saline, with whatever, this is how you're going to do it. So it's a piece of cake to get it done. So this is really a utilitarian, necessary, like way to inject this area.
Thanks.
All right, let's move on. Now let's talk about glenohumeral joint. Now, a lot of glenohumeral joints, I hear about people using this kind of an image. I'm going to stop the video for a second. They'll show this image, and what they'll do is they'll show people to do an in-plane injection with the probe posteriorly, looking at the posterior joint. And what they'll do is they'll come in kind of from a posterior lateral angle. Now, this is the same portal that I will create to do a posterior stabilization on a posterior labrum repair. But I'm going to tell you, it's not as easy as it looks, and it's a long throw, and it hurts people more. So getting down to that region is bad. In addition to that, now not on this patient, because this patient clearly has bad arthritis and no cartilage, but you'll see a black line, kind of an area over the bone, that is cartilage. And I've seen people skim down. I've seen people come in and they'll skim and they'll take a sheet of cartilage right off of the bone because they're coming along that area and skim along the bone. So it's not as benign as thinking. People think, oh yeah, I see the joint. There's black there. No, that's cartilage. Don't go there. And then I also hear people, falsely say, oh, I don't want to hit the labrum and damage a labrum. Dude, you're not going to damage a labrum with a needle. Trust me, it's fine. Go in the labrum. It's okay. Who cares? Just don't go in the cartilage. That's worse. The articular cartilage is going to do harm to it. So that's why in this situation, what you're seeing me do is I'm doing an out of plane injection coming up underwards. What I'm doing is I'm measuring the distance from the probe surface down to the joint, and the joint is right where that labrum is, right at that glenohumeral joint right here. So that's where you want to be. And I'm going to be shooting for this spot here or this spot here, because you can see the labrum right here. Okay. And so basically this is your joint right here. So this is what you want to hit. So you want to be that distance down. And so you're going to angle up. The two things you have to worry about is, one, careful of your needle. Don't contaminate your needle. I've seen too many new people come up and try to become too close to their probe. Get away from your probe. Get about a centimeter or two away from your probe and then angle up at it. Okay. Also, when you get there, if you're not in there and you're superficial, like you're here in the infraspinatus, don't keep pushing forward. You're going up. You got to pull back, reorient, and go more flat angle. So that's kind of the teaching point you need to worry about. So as you'll notice, when I start the video here, you're going to see actually the joint is filling up with fluid. So I'm clearly in the joint. In fact, you can see my needle. My needle is right there. So this is an out of plane technique. I prefer this technique. I think this works much better myself. So here we go, same thing. And obviously there's a cadaver, so I don't care if the needle touches. So I'm right there. And what I'm going to do is you're going to see my needle right here, and I'm going to be moving. I'm going to jiggle it around once I get in. So there's the humeral head. There's the glenoid. There's the labrum. Here's your infraspinatus right here. Okay, you got your deltoid up here. And so you're going to see my needle right in this spot here. And I'm going to jiggle it for you so you can see it. It's going to be right there.
Yeah, and I think seeing the ultrasound anatomy really helps know why this one should really be out of plane, because like the joint is sort of this cleft like this. So, you know, if you're going to come in from the side, you're definitely going to end up skiving. It's hard to kind of get in if you're coming like this angle to hit the pocket.
Cartilage? There's the cartilage right there. See
yeah.
that? So everyone says, oh yeah, just hit this spot here. That's cartilage, bud. Don't hit that spot. You want to be superficial, that black area. But then you might get in the infraspinatus and then you're not in the joint. So that's why I say this is actually a much, much easier, more reliable shot, especially for people learning how to do this. There's less risk to do it this way. All right, AC joints. AC joints are not as easy as they make it look. So I put up this picture because this is an old school picture. You can tell by the really bad ultrasound image about how bad this image was. But this is like one of the few images I could find to show you a needle coming into the AC joint. This is not easy, and this is really hard. Coming down at an acute angle, you might lose it because of anisotropy. You basically are not going to see it very well. And then also, the problem is people don't understand that the AC joint is angled, that it's not up and down. It doesn't go straight up and down. There's an angle to it. And I can prove that to you by showing you an X-ray. So there's your X-ray, see? And you see how there's an angle to the AC joint. It's not up and down. And so you've got to understand this angle, and that's why putting your probe on top and just trying to drop down and come into it isn't going to work, because you need to know the proper angle. Now, I'm going to show you a way to do this to make it easy, but this is actually something you have to understand about the anatomy. So coming straight up and down and going straight down is not going to work for the majority of the population. You're going to need to angle this more this way. So for this image, you have to be angled a bit this way to get down into the joint, because your clavicle is going to come up over and the acromion is going to be slightly down. So there's going to be an angle to it. Now, understanding that, what we can do is that if we do it correctly and we're able to get down, you can do an in-plane injection and you can see the whole disc of the AC joint. And there you can clearly, I'm filling up that AC joint. And there I see I've moved my transducer. I'm over on the bone. Now I'm off the bone in the disc. And what's nice is you can see where you're going, because the problem is it's a three-dimensional structure. You might end up being too superficial or being too deep, then you're not actually in the joint itself. That's why doing this with ultrasound, with actually the technique I'm going to show you, will really help you get it right. So here's what I want you to do. This is now just showing you the AC joint, and we're kind of coming lengthwise from clavicle to acromion, so you can see the whole thing. You can see like that dip there. But what we're going to do is now I'm going to switch it 90 degrees. I'm going to come down on top of it. Oren, would you call that short axis or long axis? What's that called for that?
Right now, I would say you're in a long axis. This I would call kind of short axis. Yeah.
Call it short. All right. So we call it short axis. Okay. So what I want to do now is we're going to come over onto the bone, come up off the bone onto the bone. And then what you're going to do is you're going to look for that area where there's no more bone and you know in the AC joint. Now, if you see bone at the bottom of your picture, you want to start angling it. Now, once you have the proper angle, you can then follow a line down, and then you can pretty much come directly into the joint and then hit it straight away. So it's not going to be straight down, but your angle of your actual transducer will show you how far to go. You can measure off your screen to know, for example, this was 1.2 centimeters down. And so that I can get directly into it. And I can actually still, here, I've made an example of going past it. Here, I've shown you I'm in front of it, and now I'm in the middle of it. So this way, you're going to be point specific in the AC joint itself. You're not going to miss this. I use this for a lot of small joints too, like, for example, thumb or finger, if you want to get into one of the small joints because it's rounded, this really helps you be able to see into the joint better.
For those superficial joints before, I always just thought you had to go out of plane. I never thought about, kind of rotating onto the joint space and then injecting that joint space in plane. It's great.
Yeah, and I'll tell you, doing out of plane is actually more problematic because of the irregularity of the joint surfaces, and you're going to more likely miss and not hit it. So that's why I really prefer the in plane, as you say, short access direction for this.
Great.
Cool. All right, surgical applications. In terms of surgery, being in the OR, the thing is that I have to really be able to identify anatomy. And my finger is just not that good, and it's funny. People talk about, being able to feel epicondyles, feel protrusions. And, number one, they're not always very easy to find. And also there's other things, there's other attachments that are sometimes difficult to be able to tell if you're truly on the right spot or not. So I've been a surgeon now for 21 years, I'm going on my 22nd year. And I'm telling you, I become less sure of myself as time go on because I've seen just too much. And what I appreciate and acknowledge is the tool belt, being able to have different tools in my belt to do proper things. Like I'll use arthroscopy, I'll use fluoroscopy. If I could have an MRI or a CT scanner in my OR, I would use one, but I cannot. So the only other thing I found is that ultrasound is just one more tool. It's not going to take the place of an arthroscope. It's not going to take the place of surgical technique or a fluoroscopy for the proper reason to use those things. But it can help me identify anatomy, pathology. It can help me put a needle onto something. I can use the central line function, the crosshairs. I can use all kinds of things in real time. And the fact now that I have something that's small, I can put into a bag that works wirelessly, it's a duh. This is something that I've now been doing for several years and I really like. So whether I use in plane to put my needle on a specific landmark, whether I use out of plane because it's very superficial and easy to do, or whether I'm going to use the crosshair markings and just X marks a spot and it's right under that spot, it's whatever I need to do. So I have published a couple of different papers on interventional and procedural uses. As Oran said earlier, I published several papers on different techniques of using ultrasound-guided percutaneous repairs and augmentations and guided surgeries. This has become really the future of just having extra eyes through tissue that I wouldn't have normally. And that's all this is really about. This is making sure I get the surgery done the right way. So using it for biceps tenodesis, calcific tendinopathy, loose bodies, identifying landmarks to do like an anterior lateral ligament repair or reconstruction, MCL repair, reconstruction, whatever. It just really is beneficial. So I use this primarily now. It's such an amazing scanner for what I need it to do. It's got such good ability, no cords. I can put up my iPad anywhere in the room, so it's just easy to set up and get done. So, and then now it has buttons to use. I can take pictures and do all kinds of stuff with it. So it's awesome. I started off doing this technique, I think around, 2011, 2012, using this biceps tenodesis technique. And we published this actually just a couple years ago. Actually, one of my colleagues, Dr. Barcelos down in Brazil, was really loving this technique and so wanted to publish this paper. So we put together the paper. And what we do is we basically kind of tag our biceps arthroscopically, then do the tenotomy. So now we have complete control. And you can tell this is before the days when I had this wonderful wireless system. We'd had to have the nurse hold the stupid unit in front of me. It was horrible. And then we were able to identify the biceps tendon, where we were, not just medial lateral, but superior inferior, because as we all know, the biceps exits a groove. It means that you lose the sheath and it's right there available under the deltoid before it dives under the pec. Once it dives under the pec major, it's all bets off. So being able to identify exactly where this is so critical, because a lot of techniques involve going into the subacromial space, unroofing the biceps. You could damage the supraspinatus, damage the subscap, damage the biceps itself. So it's just really not an easy technique. So this is a simple one where I can identify exactly where I want my portals, where my biceps is, so I can place my portals exactly, come in, kind of lift off the deltoid, get it off the area. Once that's done, I can then come in with my arthroscope. I can now see exactly, and you'll notice the biceps is right there. It's right in front of you. And so I'm just cleaning the area off, but I'm now kind of preparing the bed, and the biceps is kind of to the right of my cautery instrument. And now I'm going to move it out of the way. So there I'm moving the biceps out of the way. I'm now going to drill my hole for my tenodesis. Once my hole is drilled, I'm going to basically reduce the biceps into position by pulling on my proximal suture. And then once that's done, I can then put the biceps back into place. I can then take my forked swivel lock, bring it into position arthroscopically, push the biceps into the hole, screw it down, and you're done. And so this is something that just makes this really, really easy to do. It takes literally 10 minutes to do the procedure. So instead of having to fuss around, find the biceps, the ultrasound shows you exactly where it is. And here is seeing it on this one. You can see the quality of the image is so much better. Like that old image is one we did years ago with the old technology. And you can see the difference already in just the image quality. And this is wireless. And that's what makes this so much easier for me to use. So I'm able to identify where I am. I can see how I was so high up. I'm coming down the groove is gone. And now we're seeing the pec up here. So we're now too low. We want to come back up where the pec goes away, and be it we're below the groove. And then once we're able to then identify where we are, you can see I can rotate the arm or rotate myself to be able to identify exactly coming straight on. And there you go. I'm rotating the arm to make sure I'm in good position. At this point, once we've identified where we are, medial, lateral, superior, inferior, that's it. I just have to simply just make my portals and then come in. And that's what makes this such an easy procedure. And this could be done on the ankle. I've published some stuff on doing knee procedures. There's some percutaneous Achilles repairs that we've looked at. There's just so many applications for this. And that's why it's so helpful. And I don't really understand why people are just scared to use it, because it's such a simple technology.
So what's the alternative? What are people doing to find their portals if they can't identify, anatomically with ultrasound?
Exactly. So what they'll do is they'll come in arthroscopically, they'll put a suture into the groove just next to the biceps, then they'll go to the subacromial space, and then they'll cut blindly into the tissue there to be able to find that area, and then fall and unroof it all the way down to this spot here, then do the technique here. So this eliminates all that risk. And what's great is there's really nothing under this spot. Like there's, because if you go too medial, you're going to have the median nerve right there and the muscutaneous nerve right there. It's going to be, muscutaneous nerve is going to be just medial to this area. So you don't want to be too medial. If you come up a little bit, above this area, you might hit the axillary nerve. It's coming just below and then up to the right. So this spot is really a clean area that's going to be safe. And so that's why this is going to be an easy thing to do. And so it really sets your place. And you can see I've come right in and you're seeing me working right here. And I'm going to clean this area off. But the biceps is going to be right there in front of you. In fact, there it is. You're seeing the biceps to the right already. So as I clean this area up, the biceps appears right there.
Right there.
Yeah, it's right there. There it is. And so that's why this is so simple. Like, that's it. You just saw me clean it off. And now all I have to do is move that out of the way and boom, drill my tunnel and we're good to go. There's your biceps. And you see how long that took. I mean, it took no time. This was not really edited here.
Right. I mean, it makes sense. You see it and then you just kind of enter right where you saw it.
Right. So I'm not going to go through the rest of it because the rest is basically just putting the screw in, because that's really all there is to the technique. So at this point, Oren, in terms of ultrasound, it's a tool. It's like fluoroscopy, it's like arthroscopy. It's like any other tool, just use it for what it's good for. It's inexpensive. It's now completely widely available. It allows for visualization of anatomic structures very well and very accurately. It helps guide my injections and surgeries, and it can transform open, difficult, potentially dangerous surgeries into something that's percutaneous, simple, and safe. Thanks very much.
Thanks, Alan. That was great, as always. I see there's already a lot of questions flowing into the Q&A, so please keep filling that up. We have some time to get to that. While you guys are doing that, we're going to hand it over to Shelly Gunther, our clinical marketing manager, for a quick demo.
Thanks so much, Aaron. Great presentation. And, it's funny. It's like, I love Dr. Hirahara, how you make things easier and they make sense. I think we sometimes get stuck in our stuck in our ways, and we're used to doing it a certain way, but it's just so refreshing to see that there are ways to make your life easier and ultimately that are better for the patient. So I'm just going to head over, just switch over my camera, give you a little bit of a demo here of some of the shoulder structures. So bear with me for 1 second here.
So you're going to show us some scanning on a live model instead of on an anatomical cadaver.
Yeah, exactly. I'm just going to kind of demonstrate some of the anisotrophy that Dr. Hirahara talked about, and just kind of showing how important it is just to be able to angle the scanner ever so slightly to be able to see, to get the best image of that tendon. So I'll just find the groove here. Great. And so here's the bicipital groove right in here. I'm just going to decrease my depth a little bit, and then just slight rotation of the scanner either way. We want the biceps tendon to look very echogenic or bright, but any kind of angle off of it, and I can make it look abnormal or fluid filled or something along that line. So this is off angle, and now we're back looking at the biceps tendon here. And so just kind of keeping that in mind, we can have the patient rotate outwards to see the subscapularis tendon. Decrease my depth a little bit here, which is right in this area. And then we can just come back in again, and we're back into the bicipital groove, the biceps tendon right here. So from here, I'm just going to head up to the AC joint, and just to kind of show you the angle of that injection that you did. And so if we look at the AC joint in long axis, that AC joint is right here. So clavicle here, acromion here. And now if I rotate my scanner 90 degrees and I start on the clavicle, which is the bright white bone here, and then I scan laterally to the acromion, then just angling back ever so slightly, we can get right into the joint space. And as Dr. Hirahara mentioned, just that little angle to point into the joint space, right? Because if I'm seeing bone, we're too far laterally. And then from here, we could do our injection from anterior to posterior.
Yeah, that's really great. A really great technique.
But yeah, it is a little bit of an angle just to get into that joint, which I never would have considered before. So it was interesting to learn. So yeah, again, no right or wrong way. You just kind of have to figure out what works best for you, and then kind of go from there. So
that's great. Thanks, Shelley.
Good. Yeah, you're welcome.
Excellent. Okay, great. Yeah, we have a lot of questions in the Q&A, and we're going to have some good time to get to those. For there, I'm going to hand it over to Janez. And please keep using the questions, and we will have time to get to those very shortly.
Thanks, Aran, and thank you, Dr. Hirahara. We really appreciate you working with us on this new webinar series on how to ensure highly accurate and precise MSK injections by sharing your expert ultrasound guided techniques with us. And thanks, Shelley, for the fabulous live demonstration. It's always fun and exciting to see the Clarius HD3 in action. Before we open up the floor to live questions with Dr. Hirahara, here's a quick poll for you. We'd love to help everyone continue their journey in bringing ultrasound to their practice. So please do complete this poll to let us know if we can provide further information, and you can click on as many options as apply. Pricing and availability does vary by region, and we have people joining us from all corners of the world today. So please do feel free to request a quote and pricing information. We'll be happy to provide that for you. You can opt to speak to one of our experts about the advantages of wireless ultrasound. And if you'd like to discuss scanner features, we'd be happy to do that with you. You can also book a virtual one-on-one demo using Zoom with our experts to see the new Clarius HD3 in action in a highly interactive session. And we can send you more video tutorials like some of the videos that you saw today. So please do go ahead and select as many options as you wish. While you complete the live poll, I'll take a minute to introduce you to our new Clarius HD3, the world's only third-generation line of portable ultrasound scanners. Now 30% smaller and lighter, Clarius HD3 delivers best-in-class wireless ultrasound for pain management with an easy-to-use app powered by artificial intelligence and connected to the cloud. Our Clarius linear scanners are specifically designed to effectively guide pain injections with superior MSK and needle imaging. They deliver several advantages. Clarius is unrivaled for near-field and high-resolution imaging in a handheld device. As you saw today, you get clear views of nerves, vascular structures, and other anatomy, as well as your needle for safe ultrasound-guided injections. The secret lies in each scanner with 8, not 1 or 2, but 8 beamformers, 192 elements, and artificial intelligence that together deliver the image quality only found in traditional systems, but at a mere fraction of the cost. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. Clarius is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. You get free movement with no more wires getting in the way or touching your sterile prep area. And with no wires, Clarius is also so much faster to clean, disinfect, or fully encase in a sterile bag. Only Clarius delivers linear wireless scanners with an ecosystem that includes a free app for your iOS or Android devices for unlimited users. Available with our new membership, Clarius Cloud is used to easily capture and manage unlimited exams from anywhere. Your membership also includes in-app Clarius classroom videos with experts like Dr. Hirahara and onboarding with a live Clarius clinician to build your ultrasound skills. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. We'll now close off the poll in 3, 2, 1. Thank you. If you ask for more information, we will get back to you in the coming week. One more poll, we'd like to invite you to pre-register for our next webinar in our series with Dr. Hirahara, entitled Expert Ultrasound Guidance for Accurate MSK Injections, Part 2, the Knee. Please complete this poll to pre-register and we'll send you a confirmation email in the coming days. I'd like to welcome back Dr. Hirahara and Dr. Frankel to answer your questions. Please use the questions icon in the menu bar to ask your questions for our great clinicians. Dr. Frankel, I'll invite you to moderate.
All right. Wow, so many questions. Let's see if I can kind of bundle a few together. One thing people always want to know is how to identify pathology. How do they learn to identify pathology, get good at it, so that they can then guide injections to where people need it?
That is an awesome question. And I'll just tell you kind of what I did. I cheated. Basically, what I did was I have a private practice and I sent people out for MRIs all the time. And what I would do is some people say, oh, scan everyone ahead of time and learn. Yeah, I don't like that. What I did was I actually got all my MRIs. And so when a patient would come in, I'd see the MRI and be like, oh, hey, you have a cuff tear, or you have a partial cuff tear, or you have this, you have that. Hey, can I scan you? And basically I was just for free, like I wouldn't charge them. And I would just ask them for my education. Could I scan people? Can I just go and see what I wanted to see, learn how to like really prove to myself that I could see the pathology that I know was there because I've already proven it. And if I did a surgery and I saw some pathology, I would then want to scan it and check it out. So basically it's experience. And you just got to learn, and you got to learn. And the hardest thing to diagnose, as we all know, is normal. It's so easy to say, oh, that's not normal. But it's hard to be really confident that that's normal, that's not. And I think the best way is just kind of just do as much as you can. And for me, it was, yeah, you can go to courses, you can be taught, but I'll be blunt. The best way is to teach yourself. Oren, what do you think? I mean, that's just me.
Yeah, I think, learning, just practice. There are some really good resources out there that can get you oriented with how to do the musculoskeletal scans, particularly because they are quite complex. Especially things like the shoulder, and really getting good at ligament identification, and then, yeah, identification of pathology, but nothing will beat the hands-on practice. You can watch videos as much as you want, which is important for image identification, but image generation, which is the hands-on piece, is really just practice. And then, like you said, kind of getting that gold standard of, the downstream radiology studies for a while, to really know what you're seeing and confirm. It's really helpful.
I'm lucky. I read all my own MRIs, all my own X-rays, all my own CTs. So I'm used to looking at the pathology. I'm used to looking for what I want to look for and what I want to see. So going to an ultrasound image, what I do is just reverse the image of black and white of what was pathology and not was easy. So it really wasn't that tough. It just took time. That's all.
Yeah. Yeah. And for procedures, we usually like to, advise people to kind of do it in a staged way. Like you kind of do the safest, lowest risk procedures first, where, there's the least margin, the biggest margin of error and like no other critical structures nearby, that kind of thing. And then you sort of advance the technicality further and further as you go on.
And if I could jump in, there was one question I saw about people asking for glenohumeral joint going posteriorly, going from medial to lateral. And I don't recommend that because what happens is the glenoid gets in the way. And so it's actually not a good direction to go. And you're aiming directly for the articular cartilage on the humeral head. So I really wouldn't do that direction myself. That's not advisable.
So there's a lot of questions here. I don't know how to summarize them together, but everybody, we get this a lot of, how much do I put in each place when you do an injection? What do I put? Like, is there a kind of a cheat sheet of what you do? Yeah. How much steroid wear? That kind of thing.
Absolutely. And there is a generality. The generality is one, don't use corticosteroid if you can avoid it. That's just number one. I'm so anti-corticosteroid because there's been a lot of recent studies coming out, especially in the last 5 years, that have been showing very clearly that corticosteroid prior to a surgical procedure, like with rotator cuff repair, significantly increases the risk of failure. Significantly. And that's even just with one shot, and it is temporally related and number of shots related. So if you can avoid cortisone, if I can get you guys to do any one thing and avoid cortisone, that's what I'd ask you. Now, there are some reasons that you do cortisone and it is very effective and it is recommended. In that situation, 1 cc of whatever you decide, Kenalog, triamcinolone, whatever it is you're going to do, there's not a big difference between them. There are subtle differences between them. You have to go through and decide what's best for you and what you think is best. It's not that one is necessarily better than another. There's advantages and disadvantages, but do small doses. And also don't do a bunch together, not like 2 knees the same day, like spread them out over the span of a couple weeks, because even though you're doing a local injection, it still has global effects on the patient. And so, like, for example, you better warn someone if they're diabetic, your blood sugars, you better watch them over the next several hours because they could skyrocket. So cortisone is not as benign as we think it is. So just be careful. And granted, I'm a big biologics proponent, I admit it, but cortisone, just be careful.
Nice. And then how about, maybe the cousin question to that is like, what size needles do you use? What gauge, what length? Yep. Can you give us a sense?
Yeah, length is whatever you need to get there. I mean, that's the bottom line. And for example, like people think that a 1.5 inch, needle on a knee is appropriate. It is if you're going suprapatellar injection, lateral, portal, in plane. If you're coming anterior, like an anterior medial or anterior lateral portal, like with arthroscopy, no. In fact, I got a good slide that shows that you need a minimum of 4 centimeters to be able to get to the joint if you're coming from the anterior aspect. And a 1.5 inch needle will not get you there. And if you go more and use a longer one and you bury it, you might end up being in a cruciate. So again, I just don't like that portal, but we'll talk about that on the next video. I think we're set up for knees in January, right, Oren?
That's right. Yeah, knees are next. Knees are next.
Next.
So a lot of people want you to do a little bit more or describe a little bit more your sterile prep, maybe like a quick review of what that looks like. Again.
So number one, cleaning the probe, yes, very important. Nothing alcohol. So, and I'm not talking tequila or whiskey. I'm talking about no ethyl alcohol on the probe because you'll destroy it. If you use ethyl chloride, as you saw me use to numb the skin, get that thing away. You'll destroy your transducer. Okay, so don't let it ever touch.
That's why you take the probe off when you spray and then put it back on.
Literally, I'm like this because I have destroyed probes before not knowing about this. So trust me, it's an expensive mistake. So yeah, don't do that. So clean the probe, it's important. So how do you clean it? But in terms of clean it for sterility, that's not pertinent because I told you that number one, if I do it in my clinic, my probe and my gel is never going to come close to my entry site ever. It's far away. So that doesn't matter. Number two, if I do it in surgery, well, it's going to be in a sterile bag. So that doesn't matter either. And in terms of sterility on the skin, sterilize how you need to. If you prefer a big area because you're worried about, contaminating yourself, do it. If you're worried about contaminating yourself, upside over it, fine. Use sterile gel, fine. There's no wrong answer. What it comes down to is, what is your comfort level? What is your comfort with sterile technique? And so that's where it comes down to. So it's not me telling you what to do. It's what do you do best for the patient? Oren, would you say that's fair?
Yeah, I mean, I think the place I've seen people get into trouble is when they have the probe. I don't have a probe in my hand, but there's too much gel. There's a ton of gel, and they're going in really close to the probe with the needle, and they hit the gel. And that's where you're like, okay, you just hit the gel. And especially if it's from one of those bottles, that's questionable. You're going into a joint. I would be a little nervous about that. So because of that risk, especially I work with a lot of learners, I make people always use sterile gel packets, and we put a tegaderm over the probe. It's the same thing as the offsite, just a sterile surface, and we clean the skin so that if there is that mistake of a little bit of gel, I know at least the gel was sterile going in, and the chance of me contaminating anything is pretty low.
Yeah, I totally agree with that 100%. And again, I'm not trying to tell people how to do it. I'm just giving them advice about what to think about as you make decisions what's best for your patients.
But in the OR, you're doing food. I mean, you're full sterile. And it's pretty easy with these. You drop them in a sterile bag, like you would do for any other sterile procedure, and you're done.
That's what I love. The fact that I can't put it in a sterile bag, and now I don't have this stupid cord coming out that I have to worry about.
Yeah. The cord was always like a real hamper. Yeah,
it's just a godsend.
Yeah. Okay, I'm going to skip to knees because we're going to talk about knees on another one. People want to know, so if you're not using corticosteroids, give us a hint about what you do like.
It depends. I use a lot of PRP. I do bone marrow concentrate stem cells. A lot of the other stuff that was on the market previously, they have appropriately taken off the market because I've never agreed with some of them because the science is iffy. And so I'm not going to mention those names. But, the bottom line is that, I do use a fair amount of PRP, but I am a big fan of leukocyte poor. I know there's some indications for leukocyte rich. I really almost never use that, frankly, and I have my own reasons for that, and I can go through them at a different talk if we need to. Stem cells, again, I use them, not nearly as much as PRP because I feel like it's not as necessary, but there are some things that you do want it for over PRP that it definitely works better for. So again, it just depends on the indication. And by the way, I do use hyaluronic acid, I do cortisone, I do saline, breaking up of calcium. So it's not that I'm stuck on a biologic. I just try to find the right tool for the right job. That's all.
And do you use local anesthetics when you do your injections?
If I use corticosteroid, I do. If you use a biologic, you cannot, because the the lidocaine and the corticosteroids actually inactivate the biologics, and that's been studied well by Mazaka out at UConn.
Okay, so bad news. All right. Great. I think we have time for one more. Do you ever do nerve blocks? A lot of people want to know if you do nerve blocks.
I have done them because I had to move my anesthesiologist out of the way once or twice because it wasn't going so well. So I kind of just did it. But I try not to. I'm not an anesthesiologist. Yeah. So, but I do know how. And
we do have a lot of other webinars on a lot of nerve blocks. People do use the same probes for both, and different people feel different comfort levels depending on their level of practice of what they use it for. So,
well, actually, it's funny. People there. Sometimes I've been in the OR and the ultrasound machine that's in the OR is kind of mediocre to bad, and they're having trouble. So I whip my thing out and I hand to them and say, "Here, why don't you use this one?" And they're like, "Whoa, we like this."
That's pretty awesome. Yeah, and then they hand it back to you for the surgery. That's pretty
exactly.
Very cool. Very cool. Well, we are at the top of the hour. I want to respect people's times. If we didn't get to your questions, we will be following up with you, but hopefully we answered most of them that we were able to reach. Janez, I'm going to hand it back to you.
Yeah, thank you so much for all your questions. We've had dozens and dozens. Again, if we didn't get to your particular question, we'll follow up with you by email in the coming week, and you will all receive a PDF copy of the slides and the webinar recording as we make that available in the coming days. I'd like to thank Dr. Hirahara for sharing his best practices, and a very, very big thank you to all of you for joining us. We hope to see you again for our next webinar with Dr. Hirahara on expert ultrasound guidance for accurate knee injections. In the meantime, have a wonderful day and keep scanning. Thank you.